Good morning, everybody. Welcome to the SNOMED CT starter course, alias onboarding. We are very pleased that we can offer you this webinar and that we can attend it together. Before we start, I would like to briefly introduce myself. I'm Grit Zimmerman and I'm part of the National Release Center team for SNOMED CT, which is located at the TMF office, and I'm supported by my colleague Juliane Gerke for organizational stuff. So if you have any question regarding organizational things, please use the chat function. We're also very delighted to welcome Ian Green from SNOMED International. Ian is Customer Relations Lead for Europe and also Clinical Engagement Business Manager. He will give the presentations and also later Rory Davidson from SNOMED International will join us. He will support Ian for the questions. Yeah, I also would like to take this opportunity to thank SNOMED International for the straightforward cooperation and that we now can hold today's webinar. Before I hand over the moderation to Ian, I would like to give you some general information. Here on the slide, you can see the information regarding asking questions. So please ask your questions only at the end of the presentation. We have scheduled sufficient time, so around 45 minutes will be held for questions at the end. You will have two possibilities to ask your questions. Firstly, with this hand sign, you can raise your hand and then my colleague, Mrs. Gerke, will unmute you and you can ask your question personally, or you use the question mark sign. There you can write in your question and the moderator, so I or Mrs. Gerke will ask the question for you. So please do not use the chat function for questions regarding SNOMED CT. Only use the chat function for organizational questions. So, and with that short introduction, I would like to hand over the moderation to Ian. Thank you very much.
Ooh. Right, good morning, everybody. So as Grit has introduced me, I won't introduce myself again. I'm from SNOMED International, and I'm going to talk today about SNOMED CT. I've given it a title as a global terminology. What I intend to cover throughout this presentation are, in some ways, all aspects that I can think of that would be useful to you in terms of SNOMED CT. So to start off with, really just to kind of set the scene, if you think about clinical practice in general, there is an interoperability challenge that has been there for a good number of years. There are a lot of actors within the clinical space, everything from general practice through emergency services into hospitals, all the individual specialties that are involved in that, including pharmacists when patients go out of hospital and carry on treatment. All of those different actors have different types of documentation. They all use different types of terminology. They all use different systems, and a lot of the records are all in different formats. And if you think of some of the challenges, so the four that I have here, in a patient record, you could have everything from the person is having breathing problems, the fact they're an asthmatic, the fact they have asthma attacks, the fact they're diagnosed with respiratory disease. All of those will be treated as a single diagnosis, if you like, but within the record they'll appear in a good number of different ways, and really that's the starting point for SNOMED, and looking at the way SNOMED records both the diagnosis but also the procedures, the clinical findings that clinicians find within or record against patients. So a bit about SNOMED CT and its history and purpose. So what is SNOMED CT? I'm sure most of you should have worked this out by now, but SNOMED CT is a coded clinical terminology. It's there to support recording relevant clinical data. It's patient focused. It supports effective retrieval. It helps to communicate, so works on that interoperability, sharing data between specialties. And it was a result originally of a collaboration between the College of American Pathologists in the US, in the United States, and the UK's National Health Service. And both of those entities brought their developments into a single entity, which was SNOMED CT. And that collaboration formed the foundation of what we now look at as SNOMED CT. So the history goes right back, well, to the late 1970s and before that, actually. But the College of American Pathologists originally developed terminology based around pathology requirements, and it went through a number of iterations until the final version, which was SNOMED reference terminology back in 2000. At the same time, the National Health Service in the UK was developing terminology to support primary care, and they were called the recodes. And the same, they went through a number of iterations back from the early 80s to a final version, which was Clinical Terms version 3 back in the late 90s. And both of those, the final iterations, so SNOMED RT and then Clinical Terms version 3, both of those were included together to make SNOMED CT. So the purpose of SNOMED CT, so one is to provide an accurate representation of health information. It's aimed at being used by healthcare professionals and provides a level of detail that's required for current clinical practice. It's aimed to be used at the point of care. So it's about clinicians recording information about a patient when the patient's in front of them. So be that in a clinic, be that in a hospital, or if they're undergoing tests within secondary care or primary care. But it also, in addition to that, helps to retrieve and analyze that health information. So it's not simply about just recording an individual statement. It supports recording at various levels of abstraction. So it provides a lot of detail. So you will have noticed, if you've looked at SNOMED CT, SNOMED CT is very large. It's very large because of the support for various levels of abstraction. There's a lot of detail included in SNOMED CT. The target audience is obviously healthcare professionals, but it's also looking at supporting, in terms of the descriptions, the terms that are used, supports also patients looking at their records, researchers, organizations, public health, and all the other actors within a healthcare system. And it supports meeting various healthcare use cases. So it isn't just about recording information at the point of care. So what can it be used for? Well, it represents patient-based health information. It supports the recording accurately of clinical data about a clinical situation. It also supports the indexing and retrieval of that information. And the retrieval part is important because that then supports analysis based on meaning. And I'll cover that in later on in the presentation. It's important for the accurate use within decision support applications. So one of the, particularly as we begin to use more technology, decision support is playing a more and more important part in the delivery of healthcare and supporting clinicians as clinical care just becomes more complicated. So some examples of that are outcome measurements by monitoring progress over time, so looking at how well patients are doing. Public health reporting, so particularly around clinical registries, looking at how you manage infectious disease, which is particularly important at the current point in time with COVID. But also supporting the recording and monitoring of cancer and biosurveillance. And it also provides a way of giving clinicians reminders and alerts for preventative care. So when a patient's annual diabetic review is due, or when that patient is due to have a HbA1c to monitor their diabetes over time. So who uses it? Well, mainly healthcare professionals, so the end users of EHRs, but also system developers, vendors, implementers within hospitals, clinics, laboratories, but then also what we loosely refer to as the secondary uses. So things like information specialists, public health specialists, but policymakers and researchers. So there's quite a wide audience that actually uses SNOMED CT, not just the clinician recording the data. So what are the key features? Well, SNOMED, broadly speaking, has three distinct features, if you like. Everything within SNOMED is based around concepts. So a concept is a clinical idea, and that clinical idea has a unique code assigned to it. But for each of those concepts, there needs to be a human readable term, a human readable phrase, which expresses the meaning of the concept. So the concepts and descriptions provide the individual words, if you like, on the screen the clinician sees. But behind the screens, there are also relationships to each of those concepts. And the relationships are there to provide links between concept to concept and to express the information in a way which is computer processable. The primary purpose of the relationships is to support the formal logical meaning within SNOMED, and also support polyhierarchical representation. So the idea that something is a type of something else, but not just a single type. It may be multiple types of information. It also, though, supports the tracking of retired concepts. So medical care, clinical care changes over time, and a good number of terms which were used in clinical practice, say 10 or 20 years ago, are no longer used in current clinical practice, but they still exist within SNOMED. And the reason that's the case is to support the longer term analysis, so the longitudinal analysis of a record. It also, the relationships are there to support post-coordination. So post-coordination is something that I'll cover later on in this presentation. I'm not going to explain that now. So the concepts and the codes, so the way SNOMED is structured, there is one code per meaning, so there's one code per concept. The code itself, so the SNOMED concept ID, is simply a string of digits. So it has a length between 6 and 18 numbers. It's most commonly 8 or 9. And the examples I have here, so I'm not going to read them, but there's a string of digits for myocardial infarction, a string of digits for past history of MI. Each of those codes, so each of those string of digits is unique. And unlike, so some of you will be familiar with classifications like ICD-10. Unlike ICD-10, the code itself has no meaning other than to identify the concept. It doesn't tell you where it sits within the hierarchy. It doesn't give any indication of any other linkage to any other concepts in SNOMED. It's simply there to identify that concept. The concepts themselves are unambiguous. So each of the concepts are unambiguous within SNOMED. There's no duplication within SNOMED. And I'll cover how that works later on in the presentation. The concepts, there's concepts versus codes versus real things is what I put here. So to try and get this across, concepts are the things, the ideas that are in people's heads. If you want to express those, then the codes represent the concepts in the terminology, but the codes refer to real things in the real world. The codes themselves, like I say, have no meaning other than to identify the concepts, but each of those concepts refer back to something in the real world. Descriptions and terms, so the description is a term string just attached to the concept, so it means something to a human reading it. The term string is just a sequence of readable characters. So the example I've got here is immunosuppression. The description types, so within SNOMED, every concept is identified by something that we refer to as a fully specified name. And that fully specified name is completely unique. So if you look at FSNs throughout SNOMED, there are no duplicates. And we run quality assurance checks both as we're creating SNOMED, but also as part of the release process to ensure that statement is true. But for each fully specified name, there can also be allocated a number of synonyms, maybe one, maybe multiple synonyms. The synonyms themselves may not be unique, so the same term string can be associated with more than one concept. So for example, if you talk about immunosuppressive therapy, which is a type of procedure, it has a synonym of immunosuppression, and that synonym is identified by a concept ID, which we've talked about, but also a description ID. And the description ID works in the same way. It's simply a string of characters to identify the word immunosuppression. That, alongside the concept ID, makes that immunosuppression unique in terms of immunosuppressive therapy. But immunosuppression can also be a finding, so a patient can be immunosuppressed. The immunosuppression finding is obviously very different from the procedure, but that also has a synonym of immunosuppression. But that immunosuppression synonym has a different description ID, and the same applies. That description ID will be associated with the concept ID for immunosuppression finding, making it unique. So when you come to do any analysis, although the term string is the same, there's a way of identifying back to the concept that those are two very different concepts. So a bit about, I mentioned post-coordination, so a bit about pre-coordination and post-coordination. Within SNOMED, over time, a lot of descriptions have developed where everything is within a single code. So the representation, which we refer to as pre-coordination, is the representation of clinical meaning, just using a single concept identifier. So SNOMED includes a pre-coordinated concept for fracture of femur. That has a single concept code. It has relationships added to it. It has synonyms, so different descriptions added to it. But also SNOMED supports post-coordination, which is the representation of clinical meaning where you combine two or more concept identifiers. And we refer to that as post-coordination. So SNOMED has within it a number of other concepts. So it has a concept for fracture of bone. It has a concept for finding site, and it has a concept for bone structure of femur. So SNOMED supports the use of expressions where those can be put together. So you can have a fracture of bone with a finding site of bone structure of femur. The clinical meaning is identical, obviously, to fracture of femur. But SNOMED, because of the relationships and the representations, it supports both representations, but also makes them computably identical. So even if they've been recorded in a different way, when you come to analyze the record, you can use then description logic to actually work out the equivalence between those two different ways of expressing the same thing. I've mentioned relationships. So the relationship types, there are a number of different relationship types. One is definitional. So they're statements that are made within the SNOMED release, and they're statements which are necessarily true about a concept. So, for example, a procedure site, if you're talking about a procedure will have a procedure site. That is always true about that concept. But then there also may be added to it a number of qualifiers. So qualifiers can be used, for example, to specify laterality. Within there are also we also have historical relationship types. So not only do we support the recording of historical data, so when something is retired from current practice, Each of those relationships also then provides a pointer to an active concept. So something is no longer used in clinical practice, but something else currently is done. Then SNOMED would provide that level of detail within the historical relationships. We also have what we refer to as additional relationship types. So they're recording around non-definitional information which is distributed. So things about the subject of the record, defining how the concept is to be used. A lot of metadata falls under that category. So I've mentioned this idea about active and inactive concepts. So an active concept is something that's obviously intended for current clinical use. An inactive is no longer intended for clinical use. But the release file itself contains both active and inactive concepts and identifies which ones are which. Like I say, each of the inactive concepts, they're there to provide a historical record. So particularly when you look about longitudinal data analysis, it becomes very important, particularly at the population level. So those are all about the concepts and the terms, the relationships. In the way SNOMED is organized, we use something which some of you will have come across before, but it's something called a directed acyclic graph. So a directed acyclic graph is just a set of concepts which are connected to one another by lines or edges, in which each connection has a specified direction. The connection, it follows the directions of the connections and enters a loop, which is why it's called why it's referred to as acyclic. This provides a support for logical subsumption of relationships from a single root. Each of the attributes, so each of the attributes have a value. So a relationship between two concepts is where one concept specifies the value of the other. So for example, you'd have finding sites would be the attribute, and the value would be left forearm. The description logic definitions of each concept code, they provide structured combinations of relationships, and I'll show you how that works in a moment. So a directed acyclic graph, so it's a structure based, SNOMED's based around and is a hierarchy. So the root concept, so the black dot at the top of this, is something we refer to just simply as the SNOMED CT concept. But everything below it within that hierarchy, so if you take the example of A is a type of B, but it means that all instances of A, by definition, are also instances of B. And that follows all the way through the hierarchy. And that just represents logical subsumption within SNOMED itself and within the SNOMED hierarchy. So to give you some idea of what that means in clinical, in real life terms, this is just a hierarchy based around fracture of femur. But if you look at the two bottom terms here, so closed fracture of subcapital section of femur, closed fracture of base of neck of femur. Both of those are a type of closed fracture of neck of femur. But the closed fracture of the subcapital section of femur is also a type of fracture of the subcapital section of femur. And either way that you go from the subcapital section of femur, all of those will point to the top of that. So they're all a different type of fracture of neck of femur. But it's a way that the graphs are actually built up, so the relationships are built up to take into account relationships between concepts. So this goes back, like I said, if you think back, some of you will be familiar with things like ICD-10. ICD-10 and classifications do something similar, but their links are only to one concept. So, if you were looking at this in a classification view, then closed fracture of subcapital section of femur could only have one link. You would have to choose to either make it closed fracture of neck of femur or you would make it a fracture of subcapital section of femur. It couldn't be both. Now, the reason that's important goes into data analysis, and that I'll cover in more detail later. So the defining relationships, this is just a very simple view just to get the point across. But if you think about how SNOMED is modeled, so how those relationships work. So pain in the calf will have a finding site of calf structure, but pain in the calf is also a type of pain in the lower limb. But the pain in the lower limb will have a finding site of lower limb structure. But if you look on the right-hand side, calf structure is also a type of lower limb structure. And then as you go from pain in lower limb, pain in lower limb has two parents, one being lower limb finding, the other one being pain. So pain in the calf has a finding site and a calf structure, pain in the lower limb, finding site of lower limb. But the pain in the calf and the calf structure gives you some idea of the attributes and the values. The attribute being finding site, the values being in this case lower limb structure or calf structure. So description logic definition. So description logic is simply the representation of semantic knowledge, and that allows formal reasoning to be applied based on axioms that state the relationships between concepts. We use an approach where which supports description logic definition, where concepts are fully defined. So a concept with a formal logical definition, which is sufficient to distinguish it from other concepts within the same terminology, is the meaning of fully defined. So the examples I've got here, so if you're looking at viral pneumonia within SNOMED is modeled with a pathological process of infectious disease. It has an associated morphology of inflammation and consolidation. It has a finding site of lung structure and a causative agent of virus. That's enough detail to identify that as viral pneumonia. Equally the same, so human pneumonia caused by human coronavirus has a pathological process exactly the same of infectious process. It has an associated morphology exactly the same, it's inflammation and consolidation. It has the same finding site of lung structure, but the causative agent is different. So the causative agent in this case is human coronavirus. Both of the above examples I've put here are examples within SNOMED of fully defined concepts. And both of those then support the description logic functionality. So I've put in here a bit about the browser, really just to, some of you will be aware of this, some of you won't. SNOMED International has its own browser. The browser provides access to the international edition of SNOMED, both in English, and the international edition, we also have an international Spanish edition. The history of that goes way back to the history of the inclusion from the US side. So the US, the drive was from the College of American Pathologists. But the browser also provides you with access to locally developed extensions, so what we refer to as member extensions. So things like the Argentina edition, Australian, Belgian, Canadian, Danish, you can read them for yourselves here. There's also the ability down the bottom to actually browse all extensions, as well as the extensions we host. There are also some externally hosted, so we also provide access to the UK edition via the same browser. I've put the URL at the bottom of the screen here, so the URL is just browser.ihcstotools.org. When you first click on, you'll see a pop-up screen, which is basically just accepting the license. So SNOMED, as you'll be aware, is a licensed product. So although the browser doesn't stop you looking, it does expect you to accept the license when you do so. The first page you'll hit, so if you choose to browse the international edition, The first page that you will land on gives you the view that you're seeing in front of you now. So on the left-hand side of the screen, you'll see is the taxonomy view. So with SNOMED CT concept at the top. So if you think back to the directed acyclic graph, that's the root concept. And then below it, we have a series of top-level hierarchies to give you some idea of the content of SNOMED. So things like body structure, so human anatomy, but then clinical findings, procedures are kind of obvious, but there's also other supporting hierarchies. So things like organism, pharmaceutical, biologic product, physical object, physical force, specimen types. So it covers a range of different clinical information. On the right-hand side of the screen, so on the right-hand side of the screen, it will give you a view of the concept you're looking at. So I've chosen for this example to use clinical finding. So clinical finding, as you can see on the left-hand side, has a parent concept of SNOMED CT concept. And then also below it has a series of children. So in this case, it gives you 30. All you're seeing in the list of children are the direct descendants of clinical finding. What you're not seeing is all the individual terms below that. So the clinical finding hierarchy itself is a lot larger than 30 concepts. Within, so when you come to that view before, you'll see on the top left-hand side here, it's a taxonomy view and a search function. The search function, so in the search box here, as soon as you type 3 characters, it'll start to return the results. Obviously, the more characters you put into the search window, the more specific your search becomes. So in this case, I've typed in diabetes, and diabetes within SNOMED has 1,715 matches. And it will cover literally anything that has diabetes in the term string. If you look on the left-hand side here, it gives you a breakdown. If you think of those top-level hierarchies from the previous slide, it gives you some idea where those diabetes terms occur. So out of that 1,715 matches, there are 1,359 that appear as disorders. But there are also another 107 that appear as findings. There are another 93 as procedures, and so on down the list. The filter, so on here, the filter results, you can filter by module. So the way we release SNOMED, we release it using a modularized approach. All of these appear within the core module, which is the international release. There's also the ability to filter by reference sets. So reference sets I'll cover a bit later. If you want to refine that search, so if you're looking at diabetes and all you're interested in is disorders, you're not interested in findings, you're not interested in procedures or anything else, all you're interested in is disorders. If you select disorder, the view you'll get is to tell you what you're using. So in this case, it's disorders. You'll then see that the only returns that you get within that list is now 1,359. So everything within that list will be a type of disorder. And it's just a way of restricting some of the returns you get. So in something like diabetes, obviously the more information you can put in, the better. And the more accurate the returns will be, dependent on what it is that you're looking for within the browser. It's probably good to mention a bit about the international releases. So SNOMED International releases SNOMED CT at the moment twice yearly. So there's an international release comes out in January and comes out in July every year. The main release files are the concept file, the descriptions file, the relationship file. But within that release, there also we supply SNOMED CT maps to classifications. So there's a map from SNOMED CT to the international edition of ICD-10. There are release notes that go along with that release, and also their editorial guidance that goes along with that release. The editorial guidance itself is a living document in the sense that the editorial guidance continues to evolve, and the editorial guidance includes both detailed guidance but also examples of how things have been modelled and termed within SNOMED. Each release will be updated, obviously, with new content. So as clinical practice changes, we add new content to SNOMED. But we can also change concepts. So obviously, I've talked about retiring concepts, but also we might change existing content. So there might be new synonyms that we add over time. All of those changes are based on either user requests. So we have an online content request system. We also have requests via our help desk. And alongside that, we also undertake our own systematic content development and quality assurance. So for a number of years now, we've had a formalized quality improvement project going on, which looks at specific areas of SNOMED, looks at updating both the terms within there and also the modeling of specific terms within SNOMED to improve the quality of the information within the release. Alongside the release, there are also a number of other associated products. So we also provide some clinical reference sets at an international level. So there are reference sets for nursing health issues, nursing health actions, dentistry diagnosis, dentistry odontogram. There's a GP, so general practice, family practice reference set, which includes health issues and reasons for encounter. We also provide some linkage products, so SNOMED to GMDN, SNOMED to ICPC2, and ICMP. So that's the International Classification of Nursing Practice, SNOMED CT. ICPC2, I should say, is the International Classification of Primary Care. There are also a number of linkages which we have in development. One is a linkage between SNOMED and Orphanet, which is the rare disease classification, which is developed and hosted by INSERM in Paris. And we're also looking at developing links between SNOMED and MEDRA. So MEDRA is the classification for use for devices and reporting adverse events with devices. Each of those maps and reference sets are all updated and aligned to a particular release. So for example, if you take the nursing health issues release from the January 2020 international release, it will be aligned specifically to that release. They're done so, and some of that is to take into account that SNOMED does change over time, and there will be concepts within each of those reference sets that change over time. In terms of the map, well, as obviously as we add new concepts into SNOMED, some of those new concepts will come, will require a mapping to some of those existing release maps. So the maps are also updated. So a bit about the scope and usage. SNOMED itself, at the moment, is a collection of about 400,000 clinical concepts. And for those 400,000 clinical concepts, there are about 800,000 description terms. If you look at that, in terms of those concepts, we also provide the relationships. There are around about 1.2 million relationships. Like I've said, SNOMED is released every 6 months. The reason, part of it, which I tend to try and emphasize, is that the content within SNOMED has to continuously evolve. And some of that is, represents the ever-changing clinical needs. So clinical practice does not stand still. but it needs to continuously evolve, both in terms of new content, but also then, as I've said, revision of outdated content. Simply because, like I say, clinical practice does change, and either things, new concepts come along, new procedures, new way of understanding a diagnosis. So the information that sits behind it just changes over time. So within SNOMED, what kind of things can you code? Well, organizing the world into types or classes is the work of an ontology, and SNOMED is an ontology. So SNOMED itself focuses on classes that are useful in health and healthcare. So it's not about just organizing anything, it's about organizing things which are very specific to health and healthcare. So things like findings, disorders, procedures, but then we also refer to situations, so things about where you apply context to something. So you might talk about procedures which are completed, procedures which are planned. We then cover things like observation, which are the measurements, the tests that are undertaken. We also include body structures, so both anatomical body structures, but also the morphologically abnormal. We cover both within the body structures. We cover pharmaceutical products, so we include within SNOMED drug types. Drug types we include down to detail of dose and form. So we'll talk about a drug, we'll talk about the dosage, we'll talk about the form, so whether it's tablets, whether it's injection. What we don't go down to the level of is things like the manufacturer, things like the pack size, all of those, that level of detail is included normally within national drug extensions. We don't include those in SNOMED simply because there isn't an international agreement on what that would be. So within individual countries, there are different manufacturers. Even the same manufacturer will distribute products in a different form within different countries. We also include medical devices, and then we cover things that contribute to illness, so things like types of organism, types of substances, if forces, objects are involved. We include functioning as social history, and certainly as we move forward, we have a lot of developments, and we will be developing SNOMED content to support particularly social determinants of health, so particularly around the social history, and that will include functioning. But there are other things that are important to healthcare as well, so it's not just limited to that list above. I've mentioned kind of ICD-10 before, so it's probably helpful to understand a bit about SNOMED and classifications and the difference between them. So SNOMED CT itself provides the adequate detail for clinically recording information. So when you see a patient, you need to record as much detail as possible. To do that, SNOMED provides a broad scope for the coverage of content within SNOMED. So as you'll be aware, patients turn up with a lot of different problems. Clinical data, you need to understand that clinical data in clinical practice can be aggregated in multiple ways. So recording data is one thing, but the way that data is then used will be different depending on what the driving use cases are for that usage. SNOMED supports the links between those concepts to enable meaningful data querying. So this is about looking at how data is used, as we refer to secondary care or data analysis, but that may be used locally, so it may be used for just querying data and advising on clinical care locally. It may be done within an organization, it may be done at a national level for population-based epidemiology, but equally it might be done at an international level. So it might be done, you could have a pan-European data query looking at the care of a particular patient. Classifications, so classifications such as ICD-10, and you'll be aware that ICD-10 is being replaced by ICD-11. But classifications are essential to give a big picture of healthcare. And they're used for aggregating level reporting and billing. And statistical classifications group each code within a single category. The reason they do that is to avoid double counting. So a lot of it is around driving the use case for using classifications. So if you look at the two differences between those two, SNOMED itself has to be has the ability to develop very quickly over time. So as new things come into clinical practice, SNOMED makes them available as quickly as possible. Where classifications, by their very nature, need to be fairly static over time, which then supports the aggregated view of different types of procedures, different types of diagnosis over time. So SNOMED itself maps the classifications. The reason we do that, so one is to support the use case of aggregation, so the use case of data querying. The maps work in a particular way. So if you look at the map we produce to ICD-10, we provide a map from SNOMED to ICD-10 to meet the use case of an organization recording data using SNOMED CT, having a requirement to report upwards, if you like, using ICD-10. So the map allows you to walk and automate from that SNOMED content in the electronic health record to transform that into ICD-10 to give you the ability to then produce the reports that are required. So a bit about, I suppose, where we sit, and I've used this visual a number of times before, and it's just a way of trying to simplify what I've just explained. If you think of the bottom, so the thing that's in blue here at the bottom is about terming. So if you're looking at using or recording data in clinical records, within clinical guidelines, within audit, within decision support, you use terming, and that's where SNOMED CT fits. But to do that, you need hundreds of thousands of clinical terms to do that, because the nature of clinical care, the nature of medicine is complex. Within, though, if you go up to a classification, so classifying level, that really supports things like data sets, which are produced for local and national planning, for contracting, national needs assessment, epidemiology. To do that, you don't need hundreds of thousands of clinical terms. What you do need are thousands of categories. So you need to group those clinical terms into specific categories to support the data aggregation. Then as you go up to the top, you have grouping. So some of you will be familiar with this, some of you won't be, but if you're running a health service, you have this idea of grouping where you create resource groups which support things like resource management, costing, contracting, needs assessment, and service planning. For those, you need hundreds of groups. So those are based around taking the categories which are specified in the middle, which then use the terms which are collected in clinical records, which are at the bottom. So each of them work together, but also have very distinct use cases. So to give you some idea, like I said, based around ICD-10, what I said, what does that mean in practice? So I've used an example here of viral pneumonia. So within ICD-10, you have a code which is J12, which is viral pneumonia not elsewhere classified. So if you recorded that in an electronic health record, what you record is J12, which is fine. So J12 will tell you that that means viral pneumonia not elsewhere classified. But then you can go through a series of questions. So does the patient have a respiratory disorder? Well, within ICD-10, each of the chapters, so each of the letters, refer to a particular type of concept. So in this case, J refers to all respiratory disorders. So anything within ICD-10 which has a J in front of it is some type of respiratory disorder. But then you can ask, so does this patient have an infection? Well, infections within ICD-10 are in a particular chapter, which is chapter A. So you would expect the code itself to start with A if it was an infection. So in this case, there is no A. So according to this, it's not an infection. But we do know that viral pneumonia is an infection. The same with the thing that follows. Does the disorder affect the lung? Well, the way ICD-10 is structured, you don't know that. So there's no chapter headings for disorders of the lung. So there's no easy way to tell this. Is the disorder caused by a virus? Well, exactly the same. There's nothing within ICD-10 which identifies, there's no particular chapter looking at viruses. So using J12, the only thing you know if you came to do an automated query is the fact that J12 is a type of respiratory disorder. If you look at the same thing in SNOMED, so one, SNOMED doesn't have the idea of not elsewhere specified, not elsewhere classified. Those are term types which are very specific to classifications. What SNOMED does have is a code for viral pneumonia. So the code for viral pneumonia is 75570004. The code itself, as we've said earlier, means nothing. So you ask the same questions again. So does this patient have a respiratory disorder? Well, if you look within the SNOMED hierarchy, yes, because it's a subtype of respiratory disorder. So if you think of those relationships take you back to respiratory disorder. Does the patient have an infection? Well, because SNOMED is a polyhierarchy, those relationships, as well as having a relationship to respiratory disorder, it also, viral pneumonia also has a relationship to infectious disease. So you do know that the patient has an infection because the concept itself is a subtype of infectious disease. Does the disorder affect the lung? Well, yes, because the way it's modeled within SNOMED has a finding site of lung structure. And the same is the disorder caused by a virus? Well, yes, because it's modeled with a causative agent, which is virus. So just the way SNOMED relationships are specified supports answering all those questions. So the main reason for the use of SNOMED in clinical care rather than ICD, so the question that certainly I get asked and we get asked a lot is, so why use SNOMED, why not use ICD? Well, the reason is logical classification. So if you think about SNOMED, unlike ICD, the logical foundation supports different ways of recording it. So the example that I've got here, if you think of recording something about kidney disease. Now, kidney disease is fine in terms of, it's a clinically valid term, but kidney disease, things about kidneys can also be referred to as renal, they might be referred to as nephro, but they all refer to the same thing. So regardless of the parents within SNOMED, which can be multiple, all the words used to describe those terms, it's possible then to make the assertion that everything links back to the kidney. And equally, the example of lung cancer that I've got here. So lung cancer itself can be a type of lung disease, but it's also a type of cancer. But within ICD, it can only be classified as one, where SNOMED classifies them as both. So I've put in here something about customizing SNOMED CT. So when it comes to implementation, customization then becomes quite an important part of implementing SNOMED, and the ability to identify groups of concepts based around specific use case requirements. And to do that, SNOMED allows the ability to develop derivatives that are often needed either to support local or national, actually, or local or national requirements. The standard format for distributing most types of derivatives is through the reference set mechanism, and I'll cover that in a couple of slides. The ref sets allow you to identify specific concepts. It also allows the provision of a bit of history mechanism, so you can look at when a concept was removed from the set as well as when it was added. And customization, like I said, can be done at different levels. So it can be done as we do it at an international level, but then within each of our member countries or within the National Release Center, within Germany, you can do that at a national level, or you yourselves could develop local or do local customization, develop local reference sets. So a reference set is simply a specification that allows the specification of subsets or value sets of SNOMED CT concepts based around specific use cases. Subsets can be used to specify specific vocabulary, specific vocab based on the requirements, like I said, the local, national, international level. And subsets allow that content then to be constrained for a specific purpose. So if you, the example I've got here, if you're looking at a cardiology clinic, you want the clinician to be able to view and quickly look at cardiology terms. And by constraining the list of concepts available, one, you enable that interaction to be faster. You also, though, then support things like relevant data entry, and I'll cover that in a couple of slides' time. But particularly when I said earlier about synonyms, although the concepts are unique, the synonyms may not be. The use of subsets then makes sure that only the concepts themselves that are valid in a particular use case are available, and it just constrains that view. Subsets can be defined in a number of different ways, and some of that is dependent on the coverage and the use case supported. The two broad ways that they can be specified. One is what we would refer to as a cherry pick list. So literally where you've created a value set, you've gone through SNOMED and you've picked out the specific concepts that you require in that subset. The other more common way of specifying a subset is where you look at the SNOMED hierarchies and you decide on a particular concept and all its children. The latter is the preferred way. One, because it involves it involves less work in terms of maintenance. So if you specify using a hierarchy, then as hierarchies change, your specification will change accordingly. If you use the former approach, so if you use the cherry-picked approach where you pick individual concepts, that involves a lot of work every time we do a release to ensure that that use case specification maintains alignment. So a bit about using, I suppose, SNOMED. So if you're using SNOMED to create a subset for a particular item in a clinical record, there's a number of rules that kind of apply. One, which I've put in red here for a reason, one is don't search blind. So what I mean by that statement is don't go into the international browser and put in a term and then assume that everything that's returned by searching with that term will be included in your subset. It won't be. So start with the use-defined set of requirements from source materials and search SNOMED based on those requirements. The requirements need to be detailed enough. So for example, using an existing record content, using the contents from the assessment scale, using might be a pre-formatted nursing plan, using billing data requirements that have a clear set of requirements that are very detailed at the start, so you know what concepts you require to meet those requirements. Like I said, subsets that we produce as subsets that we've developed are all based on international use cases. The way we develop them is through the use of pulling together a group of international subject matter experts, and the way we do it internationally is often in collaboration with international professional organizations. So things like the dentistry subset, so the dentistry diagnosis, the odontogram, we have a, well, in fact, we have two groups. We have a clinical reference group, which is a broader group of clinicians who have an interest in dentistry. But specifically for the reference sets, we also have an editorial panel made up of subject matter experts from that group. They meet a couple of months before each release to review changes to SNOMED and potential changes to the subset and agree those changes, which we then make prior to publication. So earlier I've mentioned maps, so it's probably worthwhile giving you a bit of explanation about mapping. So mapping itself is about identifying associations between particular codes, concepts or terms that are in one code system, and then codes, concepts and terms in another that have the same meaning. So maps are developed with a documented rationale, and they're developed for a given purpose. The reason that the given purpose is important, there can be different maps between the same code systems, but they meet different use cases. The maps themselves are directional, so they run from one code system to another. As I've said earlier, our preferred direction, if you like, is from SNOMED, so really to support the use case of detailed information being recorded in SNOMED, in an electronic health record, and then aggregating that data up into a classification format then for reporting purposes. SNOMED CT specifications and contents support both simple maps, complex and extended mappings. Simple maps are, as you would expect, where you're specifying simply a one-to-one relationship between a SNOMED concept and a code that's in the target scheme, so in the other classification, for example. And the way we publish these are using a simple map reference set. But we also include, or also can include, both complex and extended map reference sets. And those enable maps from a single SNOMED concept to a combination of codes rather than a single code. It also allows you to map from a single code to a choice of codes in the target scheme. And also there will be the inclusion of things like mapping rules in there. So you can go from a SNOMED concept to a series of concepts, and which of those series you choose is based on a particular documented rationale. As I've said, mapping has a direction. We do mainly from SNOMED. We distribute via the reference set mechanism, and we have agreed principles and rules for each map that are based on particular use cases. So the current maps that we produce and distribute, so one is from SNOMED CT to ICD-10, which is the World Health Organization release, as opposed to clinical modifications, which are developed at a more national level. We also map from SNOMED CT to ICD-O, so the cancer staging classification that is supported by the World Health Organization. We provide maps from SNOMED CT to GMDN, so the Global Medical Device Nomenclature, and then also to ICPC2, which is the classification of primary care. Like I said, I mentioned earlier, the maps under development. We have a map under development to MEDRA, and also Orphanet. This is just to give you some idea of, give you some examples of what I've mentioned previously. So SNOMED code for carpal tunnel syndrome, there'll be a map advice with that, tells you which ICD-10 code it goes to, which in this case is G56, but also the fact that when you do that, to always consider the laterality specification. So carpal tunnel can either be on your left or your right, or it might be bilateral. You might have carpal tunnel in both your left and right. Where something like blood in urine, so blood in urine, irrespective of how it's, if it's recorded as blood in urine, it will always go to R31.9 in ICD-10, which is hematuria unspecified. The same with mucocele of appendix, that will always go to K38.8, and that one will always go to other diseases of appendix. You'll see here the examples I'm using give you very specific clinical codes in SNOMED, but what you're mapping to in ICD-10 does not always have the same level of specificity. So it doesn't always map, the words don't always match. So blood in urine doesn't map to blood in urine in the classification. But blood in urine within SNOMED will have a synonym of hematuria, but it won't have any link to hematuria unspecified. Hematuria unspecified is particularly unique to ICD-10 and classifications. A bit about translation. So translation, we provide as part of the international release SNOMED in US English. We also provide the international release in South American Spanish. Like I say, the Spanish, the reason we do the Spanish is more historical. The translation itself, so as translations evolve, so if you think back to when I showed you the first screen of the browser, where you have things like the Belgium edition, the Netherlands, the Dutch edition. Translations are the responsibility of individual member countries. So we don't take responsibility for translating SNOMED into all the different languages. Well, for two reasons actually. One is a very simple one around resources. So one, we don't have the resources to do that. But more importantly, we don't have the expertise to do that. The individual translations are then released as part of a member release. So if you take the example of the Netherlands, the part of the Netherlands release includes the international release and also Dutch translations of concepts that they've translated so far. So some current examples of countries that have translated, and this isn't a complete list, but things, there's a Swedish example, Dutch, Danish, there's Canadian French, there's also European Spanish, which is different from South American Spanish. But then we also have language variation examples. So, I'm, as you probably worked out from the accent, come from the UK. Within the UK, we distribute SNOMED in UK English. So a lot of the spellings are different from US English. So we distribute a language variation in the UK. So you get all of SNOMED, but with UK English. Equally, the Australians do exactly the same. So the Australian release includes Australian English, which includes just different spellings. So it's not necessarily different. The words are spelt in a different way. The underlying heuristics around translation. So one, the driver, as with the point I made earlier, is the fact that the FSN, the fully specified name, needs to remain unambiguous. There needs to be transparency over the way translation is done. It needs to be systematic and consistent. it needs to be linguistically correct, and it needs to have psychological acceptability. So translation with SNOMED, we've produced a number of documents. So there are guidelines around translation. There are also guidelines around quality assurance of translations. And I provide links at the end of this presentation where you can get access to those. So the driver within SNOMED for translation is to translate the concepts, not the terms themselves. So concept equivalence is essential. So when you translate, conceptually, it must be the same thing. So concept translation requires clarifying the underlying meaning of the concept. So to do that, you need to consider the meaning of the source language term. So what does the actual, when you see the term in English, what does it actually mean? You need to look at the hierarchical position of that concept. So that will give you an understanding of what that term means. But you also need to look at the relationships of the concepts to other concepts. So what relationships does it have? Now this example, this is not one of my examples, but one of my colleagues who's from Denmark. So when Denmark started undertaking their Danish translation, there is a term in SNOMED which is sore bottom. Sore bottom in SNOMED refers to a soreness of the thing you sit on. If you do an actual translation of the word sore and the word bottom, what you get is on bund. But bund itself is just the word which means the lowest or deepest part of something, as distinguished from the top. So if you think of the word bottom, the bottom just refers to the thing at the bottom as opposed to the thing at the top. The actual translation that's required, I'm not even going to pretend to pronounce that one, but the correct translation you can see on the screen. So there's something about here about, like I say, one, don't translate the words. You do need to look at conceptually what the thing is. The translation process then follows a systematic process. So one is just read the term. So what's the term? So start at the top, then move in a clockwise direction. So then check the concepts. So what are the user relationships and where does it sit in the hierarchy? Following on from that, what are the attribute relationships? So what are the relationships which tell you something about that concept? In case of any doubt, find examples of the source term used in context in order to elucidate the meaning. So think about how that's used in practice, and does that help to inform you of the meaning of that concept? Find the equivalent concept or term in the target language, and if necessary, verify that use of the target term in context. And then obviously write the target language terms, do the translation. To give you some idea, we reviewed a number of academic papers that have been written about the use of automated translation. And particularly for European languages, automated translation will give you about a 60-65% match in accuracy. The Asian languages are a lot less. The difficulty comes with automated translation. So one is the example that I've used, that we've discussed here. So making sure that conceptually something, it's not just translating the terms, but also clinical language itself is very different. So clinicians refer to things in a particular way in the context of clinical care, and that needs to be part of then that translation process. So I said we had a discussion earlier, so I said I'd include some implementation approaches because I know that's something which a number of you will be interested in for obvious reasons. So a bit about electronic health records, so a bit about setting the scene, if you like. So making health records electronic. So one, it was a significant step forward, obviously. It improves communication, it increases the availability of relevant information. But electronic health records is only a partial solution. So recording something electronically gives you, the example of here, the picture I've put here is the footprint. So it gives you a footprint. It doesn't give you anything else. If you want to make health records meaningful, you need to have the ability to identify significant facts in oceans of data. And I do mean oceans. So if you think of the amount of individual bits of clinical information that are linked to your own personal record, and then think of that in terms of your local population, in terms of national population globally, that's, well, billions, trillions of bits of information floating around. So to make health records meaningful, you need to enable effective meaning-based retrieval. So in those oceans of data, you need the ability to effectively find the bit that you want. You need to also link that electronic health record data to authoritative clinical knowledge. So just knowing what data was recorded against a patient is not helpful for clinical care. You need to link that back to clinical knowledge. So be that decision support, be that evidence-based guidelines. And SNOMED CT represents the clinical meaning and then also contributes to meaningful healthcare records. So there are lots of different ways to implement SNOMED CT, but I've listed a few here to kind of start the conversation, if you like. So SNOMED CT can be a common language. So it allows you to communicate in a meaningful way. It allows you to integrate heterogeneous data. So it supports the interoperability side of that to bring that data together. But you can also use SNOMED as an indexing system. So you can also use SNOMED as a way to support retrieval of clinical information as the main driver. You can use it obviously as a code system, so you can use it simply to record clinical information. It'll give you an easy way of doing that. You can use it as an interface terminology, so it allows you to capture and display clinical information. You can use it as a dictionary, so you can use it to query, analyze, and report, and also to link health records to knowledge resources. So you might want to use a SNOMED code for diabetes to link to the local evidence-based guidelines for diabetes care, which may themselves then use SNOMED codes to link to individual research articles. You can also use it as an extensible foundation. So you can use it as a way to represent just new types of clinical data. So things which haven't been recorded in the past, but SNOMED has a broad enough coverage to enable you to look at new types of clinical data. So a bit about a common language. So existing systems, as I've said, if you think back to that first slide, so existing systems use all types of different languages. Some of those are widely accepted standards. Others may be locally developed systems. So we're not necessarily talking about different enterprise-wide systems. There may be local systems. You can map to and from SNOMED as a common language for communication code systems internally. So just a way of supporting internal communication. New systems using SNOMED CT don't need to worry about anything to do with maps. The picture I've got at the bottom here gives you some idea, but if you've got systems which have been using different code systems before, there will be a requirement to map both into them, so putting SNOMED into a form within that system that the system can understand. And then also, if information comes out of those systems, put it into SNOMED so it can be shared across across a network. If you have SNOMED systems which are new systems which only use SNOMED, that's obviously a lot easier. So you can use SNOMED, you can share data in SNOMED, you can take data in terms of SNOMED. To use SNOMED as an indexing system, so electronic health record systems will use local codes, they'll use classifications, they'll use text in records. You can set up algorithmic rules that map and index data using SNOMED codes, and that's useful for local analysis of SNOMED semantics. It also allows you to export those different types of data to a data warehouse, which can then support then larger scale aggregation and analysis. So as I've got on the picture at the bottom here, so you've got electronic health record systems using different codes, index them into SNOMED, and then once they're indexed into SNOMED, share them with the data warehouse, and then they'll go into individual systems from there. You can use SNOMED simply as a code system for storage, so data capture and display, and you use that for local user interface, or use it as a local user interface terminology. The interface terminology then that you're using is mapped or linked to SNOMED, and the electronic health record system then uses SNOMED for storage and to index it and to communicate it. So the picture I've got here at the bottom is the EHR system using whatever interface terminology they're using. That then has a map to SNOMED within the EHR, and then from the EHR then codes can be either retrieved for local national usage. You can use SNOMED as a dictionary, so you can use it for reporting and analytics. Decision support systems use SNOMED, and that supports meaning-based analysis. So if you think about an EHR, so the picture on the bottom here, will have a map through a query into decision support guidelines, which are then visible on the screen to the clinician. They'll also map through a query then to reporting and analytics functions. So it supports both, but it supports them by using SNOMED as a dictionary. One of the most important things around implementation is that implementation really is about a stepwise approach. So the way I've described earlier about using SNOMED, it isn't an either or. So you don't necessarily pick a particular implementation approach and then stick with it. So you only use one approach. SNOMED CT can be used as a simple code system at one end of the implementation scale, but it can also be a very powerful terminology resource at the other end of the scale. But SNOMED CT implementation is not an all or nothing. So it's not about you either choose it as a simple code system, or you go all in and go for the powerful terminology resource. Even a simple use of SNOMED has benefits simply from using it as a common coding system. As your implementation becomes more complex, it has then to deliver more benefits. But a stepwise approach then can also meet evolving requirements. So as you put a new system in, you don't necessarily know longer term all the requirements for that system. So a stepwise approach gives you the ability also for your system to evolve over time. So I've got some examples here to give you some idea of what's this done. The examples are all national approaches. So in the UK has had a national adoption of SNOMED CT. The focus initially has been on primary care systems, which was targeted originally by the end of 2018, although that kind of was a bit of a moving feast. So it was a bit later than that. The target then for secondary care at the moment is a moving target, mainly because of the current global situation going on. But it will be mandated in secondary care. At the moment, it's mandated in primary care. The driver for that was something called a report which came out in, I think, back in the late 2009, I think, which was the Personalised Health and Care 2020, a framework for action, which set out the scene for the UK moving to a single terminology and how that would work in terms of the whole healthcare system. It endorsed SNOMED CT as a single terminology to be used in all healthcare settings. And certainly as we move forward, healthcare settings includes health and social care settings in England, not just healthcare settings. Partners will actively collaborate to ensure that all primary care systems adopt SNOMED CT by the end of 2018. It was a bit later than that, but that is met. So all primary care systems now in the UK, well in England certainly, run on SNOMED CT. Scotland and Wales are moving towards SNOMED CT. And the aim was that, like I say, the entire healthcare system, so primary and secondary care, would move by April 2020. That will be moved back slightly because of the circumstances currently. We have a number of large hospital implementations, so things like Leeds Teaching Hospital, Moorfields Eye Hospital, but there are many more. So we have Adam Brooks, we have Barts Health in London, a lot of big major hospitals all over the UK. We have national imaging representation. So we have national standards for PAC systems for patient for picture exchange. Those are supported by SNOMED CT clinical diagnosis codes. We have a national drugs dictionary called the Dictionary of Medicines Devices, DMD, which also maps to SNOMED. And a lot of the national care plan standards are specified using SNOMED CT. So a lot of those national guidelines include SNOMED as part of their specification. In the United States or the US, there has been a national adoption of SNOMED CT. So under meaningful use and electronic health records certification and health information exchange, SNOMED has been adopted as one of the key vocabularies. It's recommended for patient problems for encounter diagnosis, procedures, family history, smoking status, and that's the current stage 1. Stage 2, as they move forward, also extends that into the representation of all content within problem lists. The largest, I mean, there are a lot of different implementations within the US. The largest by far is Kaiser Permanente. They're the largest non-for-profit health plan in the US. SNOMED for Kaiser is the foundation to their electronic health record system because they're literally on multiple sites across the United States. It's used directly by clinicians to encode problem lists and a lot of other clinical data. And it supports their disease management programs, so both around chronic disease, but also in terms of their just general disease management programs. In Hong Kong, so the Hong Kong Hospital Authority manages public hospitals and services in Hong Kong. At the moment, they have 42 hospitals. They also have 48 outpatient clinics, or 48 specialists, outpatient clinics. 73 general outpatient clinics. Their code systems include both SNOMED, but also then ICPC2, so the classification of primary care, ICD-10, and LOINC, which is the laboratory observation coding terminology, and also a local drug dictionary. But within the Hong Kong system, all the different types of terminologies or classifications are all mapped to SNOMED. So SNOMED provides the underlying main terminology. So SNOMED is used as a common dictionary, particularly for data analysis, for reporting, for clinical decision support, and it records everything from diagnosis, procedures, medication, laboratory, the type of organisms, part of infectious disease control. It's used to increase decision support and data retrieval capabilities. And the reason that it does that is due to its comprehensive domain coverage and the underlying description and logic which supports their use cases. It also allows them then to develop very rich and criteria-based queries. So once you have a lot of SNOMED data to work with, the queries you can run on that data, then you can run very complex queries, and the information you get back is very rich and very detailed. Singapore, so Singapore, SNOMED is part of their national healthcare infrastructure, which includes an electronic health record, which uses SNOMED CT as the common language for all healthcare communication. They integrate local code systems into that national record. They also aggregate clinical data into a patient dashboard. So they use SNOMED codes both to support clinicians viewing the data, but also their own patients viewing the data, which is in itself an interesting challenge. It supports their analysis of healthcare records, and it also allows them to develop business processes and decision support rules to support the delivery of care. They create their own SNOMED releases, so as well as taking the international release, they create and maintain a Singapore extension. So they create and maintain their own unique SNOMED codes, which are used only in Singapore. They also have a SNOMED CT Singapore drug dictionary, so they built their drug dictionary by taking the drug content within SNOMED and then extending it with the drugs and terms they require to meet their own national requirements. As you'll be aware, SNOMED is used now in more than 80 countries around the world and is growing. Government policy endorses SNOMED in several countries. So the way SNOMED is implemented within countries differs, but the way, if you take the national drivers for us, the way to endorse it nationally, and use the example of the UK, is the approach taken in Australia, Canada, Hong Kong, India, Netherlands, Singapore, the US. But we've put together some of the examples of SNOMED CT deployments on something called SNOMED in Action. I'll put a URL here that you can go and have a look at yourself afterwards. So SNOMED in Action. So SNOMED in Action is just the website that the URL will take you to. It includes examples of implementations, but also examples of clinical use cases, looking at the inclusion of clinical research projects that include SNOMED CT. And the aim of SNOMED in Action is just to give a comprehensive resource of how SNOMED is being used in clinical practice globally, both to give you some ideas, to give you some examples of how people are using SNOMED CT, but also then potentially, if you're looking at developing a particular approach, to give you someone to go away and talk to, and learn from each other, so you don't make the same mistakes, and you also learn from their experience. The SNOMED in Action domain, so like I said, give you some idea what's covered in SNOMED in Action. So clinical research, public health, there's stuff in there around computerized physician order entry, electronic prescriptions, immunization. Gives you an example of electronic health records in different care settings, also different specialty settings, but there's a lot more. Those are just to give you some high-level examples. So I'd encourage you to go in there and just have a look around, particularly if you're looking at particular or developing a solution using SNOMED in a particular way. Try and look at what's been done elsewhere and learn from their experience. So some interoperability challenges. I've put this in really just to make the point in some ways. There isn't, so one, SNOMED itself enables you to record things in different ways, but equally systems out there in the real world also record things in different ways because of the structure of the interfaces within those systems. So if you take the three examples that we have here of three hospitals, so three hospitals, and you're recording within those systems as a clinician, you want to record suspected lung cancer. Now, hospital C, so if I'll use a simple one, I'll actually work backwards, but hospital C on the right-hand side here has a single field, and you want to record suspected lung cancer. So in the box provided in the electronic health record, you select suspected lung cancer. And as a clinician, you select that, you press OK, and that's the diagnosis for that patient. In Hospital B's interface is slightly different. So Hospital B allows you to select a problem, but it also allows you to select the status to that problem. So that might be suspected, it might be confirmed. So in this case, the clinician, so I'm the clinician, I select lung cancer and I give it a status of suspected. And then, down the line as we do investigations and that diagnosis moves from suspected to confirmed, I would have the same screen in future with lung cancer, except I'd change suspected to confirmed. Press OK, and that's recording exactly the same. This patient has suspected lung cancer. Hospital A's interface, though, is a little different. So Hospital A's interface requires you to put the problem in. So in this case, the problem is cancer. The body site, so where is this cancer located? Well, it happens to be located, in this case, in the lung. And then it gives you a status, which is just a tick box. So is it suspected? Is it confirmed? Is it not found? So I put in the first box cancer, the second box lung, and I click suspected, press OK. And I'm still recording suspected lung cancer. So although the data input is very different in those three settings, the outcome is exactly the same. I've recorded that the problem this patient has is suspected lung cancer. Now, if you think of what that means in terms of the codes, so in Hospital C is a single code. So SNOMED has a code for suspected lung cancer. It also has, to meet Hospital B's requirements, also has a code for suspected cancer and the body site of lung. But then Hospital A is more detailed data requirements. SNOMED has a code for cancer, it also has a code for lung, it also has a code for the status of suspected. And if you think about the definition, so this is using the SNOMED diagramming standard. So if you go into the international browser, on the right-hand side, you'll see one of the tabs has diagram. If you select that tab when you're on a particular concept, the view you'll get will look something like this. And it gives you, suspected lung cancer. It will then give you the parents, so suspected lung cancer, if you think back to the ISAs. So is a type of suspected malignancy, is a type of suspected respiratory disease. But then it also has modeling. So suspected lung cancer is modeled with a temporal context. So this is suspected lung cancer in a patient now. It's not about something which was historical. It's not about some kind of future prediction of what's going to happen to the patient. It also has an associated morphology. So suspected lung cancer has, associated finding of malignant tumor of lung. It also has a subject relationship context. So this is about the it appears in the subject of the record. It's about the person. It's not about their family member. It's not about family history. It also has a finding context. So in this case, it's suspected. It's not confirmed. So if you think about what that means, so the lung cancer part is obviously from the malignant tumor of the lung. The cancer bit comes from the malignant neoplastic disease, and lung structure tells you it's to do with the lung. So using those same things allows you to query using the structure of SNOMED for suspected lung cancer, irrespective of the way that each of those systems have recorded. So suspected lung cancer, you will still know is a type of cancer, has a body site of lung, and has a status of suspected. Equally, you'd know that suspected lung cancer is a type of suspected cancer with a body site of lung. So it's a way of aggregating and querying the data while maintaining accuracy. Which brings us on to data analytics. So data analytics itself is about discovery and communication of meaningful patterns within data. It may describe, predict, improve business performance, and it may recommend action or a guide to decision making. It's about, so the scope of it can be the individual patient, but it might be the individual healthcare worker themselves. It might be around patient groups or cohorts, enterprise groups within a system, or even geographic groups. And the substrata is about unstructured free text documents. It might be structured documents using SNOMED, structured documents using other coding systems, or big data. Data analytics itself, so about the benefits to individuals and patients and clinicians, will feed into population monitoring, which benefits populations, will feed into research, which then informs and develops evidence-based healthcare, which then informs treatment. So the whole approach is cyclical. In terms of individual care, so SNOMED can be used to support analytics that improves care and delivery for individuals by retrieving and sharing information, reduction in the duplication of investigations and interventions, integration of decision support tools, so it helps or gives clinicians the ability to receive advice when they're giving either treatments, when looking at prescribing medications or allergies. It provides context-sensitive presentation of guidelines, so rather than just seeing the national guideline for diabetic care, you'll see it, or you can use SNOMED to provide that guideline in the context of the patient that you're looking at. It allows you to identify patients that require follow-up or treatment changes and do that very quickly. It provides professional logs and performance tracking for the individual clinicians themselves. And in terms of just managing work within a healthcare environment, allows you to generate work lists and monitor workload. In terms of population care, so SNOMED will support epidemiological monitoring and reporting. It allows you to audit clinical care and audit service delivery, and provide systems that will measure and maximize the delivery of cost-effective treatments. And so both the delivery of cost-effective treatments and also identifying where treatments are not cost-effective and therefore require revision. By doing that, it allows you to minimize some of the risk of costly errors, either in terms of ultimately patient harm, but also costly errors in terms of just giving treatment which simply either doesn't work or would be better given in a different, either a different way, potentially a less expensive way. It supports evidence-based healthcare, so you can use SNOMED to identify clinical trial candidates, so create a cohort of patients very easily. You can research into the effectiveness of different approaches to disease management. So because you can analyze the data in a number of different axes, or using a number of different axes, it allows you to view the data in a lot of detail to allow you to look at different approaches and identify which one works, which one's more cost effective, and will inform the delivery of healthcare. It allows you to also do healthcare delivery planning, so things like identifying patients who have learning difficulties as children will then inform what their requirements are as adults. So knowing how the population changes over time, and just planning for future service delivery provision, to give you some idea how to do that by using accurate, detailed information. A bit about the clinical input. So we, which you've kind of gathered from my job title, we have a focus on clinical engagement. Clinical engagement in SNOMED terms, so one is around clinical input into future developments. So SNOMED is there to support clinicians. The aim is around timely responses to clinical advances. So one of the challenges we have with SNOMED is keeping up to date with the ever-changing needs of clinicians. To do that requires us to rely on clinicians telling us when things change. If there are particularly derivatives, so particularly subsets or maps that clinicians require, we're producing, we'll have produced, and we'll continue to produce educational materials, clinically driven implementation support, and looking at how clinicians out there, we can use clinicians to clinically assure the SNOMED content. But ultimately the driver here is this thing in the blue box around SNOMED being enhanced by clinicians to support current practice, but also to support future clinical practice. There is, and I've put a website link on here, there's, that's me, just in case you want to know what I look like. I also work with 3 individuals down the bottom here, Dr. Charles Guttridge, Peter Hendler, who's a doctor from the US, and Jane Miller, who's a colleague of mine in the UK. We look at supporting clinicians both in terms of the groups, in terms of the groups that we work with, but also in terms of, like I say, coming up with guidance, and also, as I'm doing now, working with either webinars or conferences and presenting on SNOMED and helping to raise the profile of SNOMED in clinical practice. The clinical portal here, if you click on it, you'll see underneath it, there's a whole hierarchy of pages which will give you access to lots of different detail around the SNOMED from a clinical perspective. One of the drivers, one of the key aspects of clinical engagement is we have something called clinical reference groups, so they're clinical specialist groups. The way we structured them, the clinical reference groups are formed from clinical communities, so they're mainly specialist driven. They provide input into SNOMED CT. Within the clinical reference groups, there are 2 kind of subgroups, if you like. One we've kind of touched on earlier, so we have this idea of editorial groups, particularly for things like maps and reference sets, which require clinical review and updating at each release. So for each product that we produce, we have an clinical editorial group. We also have project groups that look at particular clinical aspects of SNOMED that are revision, and they're time limited groups, so they're given a task to normally to review content, to provide guidance on updates and revision of that content. And you know, as that content goes into SNOMED CT, it obviously feeds back into clinical communities, and they will continue to feed changes as healthcare changes over time. I've kind of mentioned this, but clinical reference groups, so they're there to facilitate discussion between clinicians. Each of them have a dedicated conference site, and I'll tell you how to get access to those in a moment. The aim is to provide a platform for clinicians to discuss with colleagues both questions and issues and experiences of using SNOMED. They're all open and transparent, so you don't need to log in to get onto the conference site. You can go and view any of them. If you want to participate in them, you do need a conference account to partake in the discussions. They're open to all, though. They're not just limited to clinicians in the clinical specialty. So, for example, we have a pathology clinical reference group, but on that pathology reference group, as well as pathology clinicians, there are also a number of individuals from vendors. There are also a number of nurses that are involved in that group. Linked to CRGs, like I said, are project groups. So if the pathology group had a particular project linked to pathology content, the project group would form part of the CRG, and the project group work would be available to view by all members of the clinical reference group. And the editorial groups I've mentioned, they provide validation for the derivative products. So I always put this slide in, but get involved. The clinical reference groups are there to help clinicians use SNOMED, and they provide access to your colleagues who are also looking to implement SNOMED. So talk to each other, share experiences, and learn from one another. So definitely get involved. A bit about working with standards and other organisations. So we work with other organisations and other standards bodies. The reason for that is to enable SNOMED to use other standards jointly and to interoperate, particularly around data capture, analysis, and sharing. It allows us to contribute in a coordinated way to global developments that address healthcare needs and needs of EHR vendors and users and other stakeholders. It also, though, allows us to influence some of the developments of standards globally that contribute along with SNOMED to interoperability. So it's really about us supporting interoperability. That's the key driver. It allows us to influence some of the future direction of standards and also to identify gaps within SNOMED International where we can either contribute to existing standards or new products. It allows us to leverage expertise from other organisations, and likewise other organisations leverage expertise from SNOMED. It obviously strengthens our, the position of SNOMED and other related products in the marketplace. So just as a way of getting SNOMED adopted, it's a good idea. It allows us to work with other standards to limit some of the duplication of effort and avoid some of the redundancies in work, and also to promote implementation and adoption. The way we approach it, if you like, is using a partnership approach. So we have partnership arrangements, and they're based on requirements of SNOMED International and the stakeholder groups. We have different types of agreements. So collaboration agreements, we have for agreed activity and deliverables to meet requirements for products and service strategies, and all of those form part of the SNOMED International Work Plan, and they all have allocated resource. So for example, I used the example earlier of SNOMED working with Orphanet. SNOMED International has an agreement with INSERM, who are the publishers of Orphanet. We've been working together on a project for a number of years now to bring in Orphanet content into SNOMED, so rare disease content into SNOMED. And that collaboration agreement supports both the creation of the content and also the creation longer term of a map between SNOMED and Orphanet. We also have SNOMED licensing agreements, so SNOMED CT sets. So we might license specific sets of SNOMED for specific uses. We also have licensing agreements for projects, so particular projects, of which that particular one will be familiar because that's how we've licensed the MII. We also provide licensing statements, so other bodies which link or provide links to SNOMED CT. So SNOMED CT has intellectual property, it has a copyright. So other international bodies can use SNOMED, but they need to provide licensing statements as part of them making SNOMED content available. We also provide development licenses, as some of you will be aware, certainly in Germany, because we've had a number of development licensees in Germany previously, where we enable the use of SNOMED effectively free of charge for a short time while systems are developed or you're running a research project which uses SNOMED. To give you some idea of kind of who we're working with, some of the standards development organisations that we work with, we have an agreement and working relationship with HL7. So we're working together looking at how to bring SNOMED and the fire specification to work together. We also work with HL7 on the International Patient Summary and working on licensed use of SNOMED in non-member countries. We also have an agreement with IHE to provide a global set of SNOMED CT for IHE profiles. We work with DICOM, so if you're familiar with DICOM, which is the imaging standard, all of DICOM's standards now are specified using SNOMED CT codes. We participate and are part of ISO, so the International Standards Organization, and we're involved particularly in TC215, which is the clinical terminology ISO group, both participating in the creation of standards and also commenting on the revision of standards. We have a collaborative agreement with GS1, which provide GTINs, so the global identifiers, product identifiers, working with GS1 to provide implementation on linking SNOMED CT and GTIN, so the barcodes. MEDRA I've mentioned earlier, so we're working with MEDRA both in terms of a small number of additional codes in SNOMED, but mainly focused on the mapping between SNOMED and MEDRA. We have agreement with the World Health Organization for mappings around ICD-10, ICD-0, and as we move forward, ICD-11. GMDNA, so GMDNA is the Global Medical Devices Nomenclature Association. So they provide the classification of medical devices. That informs both content going into SNOMED and also regular updating of the map that we produce and distribute every 6 months. We also have an agreement with LOINC, looking at really how LOINC and SNOMED interact together, particularly but not limited to the pathology space, so mainly in laboratory. But as you'll be aware, LOINC is expanding into the clinical realm. SNOMED has both clinical and laboratory content, so looking at how we can work together, both about supporting our individual users, but also about reducing duplication where possible. We also have collaborative working with some professional bodies. So I in particular work with GA4GH, which is the Global Alliance for Genomics and Health. They bring together a lot of different parties involved in moving the genomics information requirements forward. We have a formal agreement with ICM, which is the International Council of Nurses, and that links back to the maps I mentioned earlier between SNOMED CT and the International Classification of Nursing Practice. We have an agreement with WONCA, which is the global body for general practitioners. That supports both advice on new content going into SNOMED, but also then about the links and the maps between SNOMED and the International Classification of Primary Care. We also have an agreement with the American Dental Association, and they they help us to run the dentistry clinical reference group, but also then provide advice and support on maintenance of the various dental subsets. If you want to know any more information or have any questions, particularly about collaboration, there's the email info@snomed.org. If you send us through your queries, the picture, so Jane Miller, my colleague, who you saw on the clinical portal slide, is also the collaboration lead. So she'll give us some advice both about the current agreements we have, but also about things we have in the pipeline. So a bit about finding out some more about SNOMED. So one, there is a SNOMED starter guide, the link for which is on the bottom here. The SNOMED starter guide will take you systematically through things like the benefits, but also basics around the logical model, concept model expressions, and also down to the release schedule. So similar to what I've covered here. We also now have the starter guide in German. I have absolutely no intention of trying to talk German to you and explain what's in the contents. You can read those for yourselves. The link on here will take you to the German starter guide. The German starter guide, well, in fact, both starter guides, you can read either on Confluence, so you can read them as a web page, or you can also download them as a PDF and read them as a standalone document. I've mentioned Confluence, so a bit about Confluence. SNOMED International uses Confluence as the main repository for all its documentation, a lot of its groups, a lot of the discussion forum. Access to Confluence is mainly open, so you can go into Confluence now. You don't need an account to view any of the content. There are a few very, very small exceptions to that rule, but mainly everything's open. There are some pages that do require you to have a Confluence account. If you do require a Confluence account, or particularly if you're looking at specific groups where you want to firstly join a group, more importantly, you need to join the discussions in a group, you will need a Confluence account for the same reason that if you join an online blog, you don't get to post things anonymously. The web address here will give you a link to the online form. Simply fill in the online form, give us the reasons why you need access, and if it's a valid reason, we'll give you a Confluence account. It's very, very simple. The SNOMED document library, so the link here will take you to this page. There are links then to overviews, to guides, to specifications. There are links to Expo. Each year we have an Expo in October time. This year we're going virtual. Normally we move the Expo around the world. So this year it was due to be in Portugal. But due to COVID, coronavirus, we've gone virtual. Next year, all being well, assuming we can meet, it will be in Portugal. But the SNOMED Expo tab both gives you links to current. So if you're looking at this at the time of the Expo, it will give you access to the current Expo presentations, but also historically Expo presentations that have been made over the years. So that's quite useful to go and have a look at what people have presented previously, and particularly where they presented on SNOMED implementation projects. We also have an e-learning server. So the e-learning server, which the link is down the bottom here, will also give you then access to presentation library. It allows you to apply for some of the learning courses, some of which are free, some of which are chargeable. Some of this content is available without a login. Some of it you can have a login and run your own account. So particularly if you're doing a course, you'll require an account to do so. And then you've got the course information and it will provide links to the course you're running on currently. If you want to learn more, the SNOMED International has obviously its own website. The SNOMED browser I've given you a link to anyway. That's the link to the document library. The starter guide in English is that one. The link on the previous slide will give you a link, like I say, a link back to the German version. The links to e-learning, they will also then give you a link then, or links and the ability to access things like the foundation course. We'll tell you about how to access the implementation course. There's content development, theory course, and showcase and past expo presentations. There are also a number of newer courses that are coming online that we're developing. So this is an ever-increasing list, if you like. And I'm going to stop there. So I've done pretty well. So I've almost finished vaguely on time. So I'm going to stop there, and then we can open it for questions, I do believe.
Yeah, thank you very much, Ian, for this very comprehensive introduction to SNOMED CT. Yeah, I think we can start with the questions. During your presentation, there were already 3 questions asked. One moment, I have to open them. So we already answered them. One moment. Okay. The first question was, will there be a German extension version of SNOMED CT in the future, and when will it be released? So from my point of view, I can say yes, there will be a German extension, and the work will start soon, so in the next weeks. And we guess that it will be probably released in 1.5 years. So, Ian, do you want to add something? Or?
So no, other than to say, so one of the things which, so you'll need a German extension long term anyway, for the simple reason that one of your main requirements will be to provide German translations, I'm assuming, or I'd be very surprised if you didn't. If you're looking at both creating and distributing German translations, you'll have to do that using a German extension. I'll mention this now. I didn't mention it as part of the translation, but the translation, obviously, you know, if you're translating into German, you're not the only country within Europe that uses German as its main language. So if I look at our current membership, member countries that currently use German, Austria is the obvious one, but then also Switzerland and also Luxembourg predominantly. What I'm looking at doing is we already have a joint group looking at global French translations, which involves members from Belgium, Switzerland, Canada, and also some large vendors from France. I'm looking at creating the same group for German. So there will be a joint German translation group going forward with membership from Austria, Luxembourg, Switzerland, and obviously from Germany. I'll work with Grits and other members of the NRC on that, and looking at, you know, how we can optimize the use of different people working on the German translation. There is already there are already some content which has been translated into German, some by ourselves at an international level, but then also by the individual countries. So getting a group together which brings all those current translations together allows them, you know, allows visibility, so allows those translations to be shared. We can also then come up with some, you know, common translation guidelines for translating from English to German, and then also look at how we distribute them long term. So that's just something moving forward. But moving from a national release, you'll definitely need a national release simply to distribute a German translation of SNOMED.
Okay. Okay, then I will read out the next question. I'm not sure if the question from Gaistar was already answered for everyone. He asked, is SNOMED a formal ontology or just a terminology translated in different languages? Well, we answered already, but I'm not sure if the answer is, everyone can see the answer.
It should have been answered to everybody.
Yeah, okay, good. Then we can skip this. I don't have to read your answer. Then the next question is how long it takes to build a new concept in a SNOMED CT. For example, a new concept for COVID-19. Yeah.
So there are two answers to that actually. In terms of how long does it take to create, not very long at all. So we have a very good authoring tool, care of Rory and his team. Mm-hmm. The bigger issue is not creating it; it's making it available. So we, as I've said earlier, we release SNOMED every 6 months. So we can create a new concept, but that concept then needs to become available for wide use. In terms of COVID, we did an interim release, so we released some of those codes ahead of time. But you still do need a scheduled release. So it's not about putting the codes into SNOMED. It's about putting them into SNOMED and making them available to the community, both in terms of using those codes and then interoperating, sharing them, doing the analysis on them. So the limiting factor, if you like, is the ability to share that data. Longer term, at the moment, we're on a 6-monthly release schedule. We're looking in the future to move to what we're referring to as continuous release, which will then make or give us the ability to make those concepts available a lot quicker to the community, the broader community at large. I don't know, Rory, do you want to add anything to that around continuous release?
Not in particular. I think the move to continuous release is likely to happen within the next 12 to 18 months. But the likelihood is, whilst we'll be in a position to do continuous releases, there'll probably be a monthly release, and we'll still have our official twice a year releases every 6 months. But yes, the aim of moving to continuous release is to move us into being able to answer to particular situations like we've had to this year with regards to COVID and anything else in the future.
Okay, when there is no addition, I would go further. There was a hand signal of Andrew Heidel, and I will unmute him. Now, Mr. Heidel, could you please ask your question loud to everyone?
Yeah, sure. I had a question related to the translation issue that a lot of the editions in other languages don't include translations of everything in SNOMED. They often are, some of the 300-some thousand concepts. So I was wondering if you had a general idea, how many concepts do you need to translate to have a useful amount in order to use it in general use? I mean, obviously it depends on the resources available and how much time I guess it takes, but is there a general amount where you could consider it to be usable for general use?
So I'm not going to give you a figure, but I'm going to give you a reason why I'm not going to give you a figure. So the answer to your question is the advice. Well, first of all, taking a step backwards, the advice that we give member countries normally is, if you're setting on the translation road, don't look at translating all of SNOMED. The reason that we say that is, if you think of the reasons why you're doing translation in the first place, is you're translating terms which will be used by clinicians in that country. Now, not every concept in SNOMED under normal circumstances would be used by a clinician in an EHR. If you're looking at data analysis is different, right? So data analysis, then, I would argue you can do data analysis. You don't need to do that in German, in French, in Dutch, or whatever. You can do that in English in terms of the analysis. But making the translations available to clinicians at the point of care is very important. One, just because so you can express the intricacies of clinical information when you record it. The way that translation has been approached by members, if they are not translating the whole of SNOMED, is to do it systematically by addressing particular use cases. So, for example, Switzerland, their prime use case for SNOMED is around laboratory medicine, both in terms of requesting the codes within the laboratory, undertaking the various procedures, and then obviously sending the results back. Therefore, their numbers of codes that they're looking at is between 50 and 60,000 codes will support that use case. Now, if you then have Austria is looking at the problem list, for example, Austria might come up with an additional, well, not additional, but their code list of codes might be everything that's in the diagnosis hierarchy, which is about 70 to 80,000 codes. So this goes back to what I said about this joint German group. The idea of getting the joint German group is to, one is to remove duplication of effort. So looking at the full picture of everything which has been translated into German and making that available. So one, I don't think it's a case of you need 180,000 codes. That's all you need to translate. I don't think it's as simple as that. One, because the use cases will be very different, but also by having this joint group, ultimately you shouldn't need to do, even if it was 180,000, you don't need to translate 180,000 concepts. You can take 70,000 from Switzerland, you can take 80,000 from Austria. I can't remember what Luxembourg are focusing on, but say they're doing a particular area with 30 or 40,000 concepts. Suddenly, if you put all of that together, you've got close to 200,000 concepts translated into German. And Germany, in terms of resource, has probably, in the whole equation, might translate 40,000 concepts. But the end result is Germany and all the other countries having access to 200,000. That's the driver for having the joint group. But I don't think it isn't quite as simple as just saying, I wish it was, but you can't simply just pick a figure and say, well, yeah, this is the core content you need to translate, do this and everything is good. I wish it were. Is that helpful?
Yeah, I think that gives a good guideline of sort of what the parameters are for how to go about how much is needed. Yeah.
But definitely, start with the focus. Don't look at the whole thing. If nothing else, looking at translating the whole of SNOMED is at best terrifying, I would have thought at the start.
I had one other question about SNOMED and FHIR, if I could ask that too.
Yeah, sure.
So when implementing SNOMED with FHIR together, there they're often the case where you can have two sets of codes or more in one FHIR resource, and this may mean two SNOMED codes at once.
Yes.
For example, at the diagnosis code, then also the body site.
Yeah.
Is there some recommendation about how to avoid conflicts between that so that the SNOMED codes don't contradict, or just to try to put all the information in the main code so that the body site isn't needed? Or how would you recommend dealing with that?
Right. So when I mentioned earlier about the collaboration with HL7, one of the groups we have is something called SNOMED on Fire, and that group's or part of that group's remit is coming up with implementation guidance for exactly the reasons you've just elucidated. So can I tell you what the guidance is? The answer is no at the moment, because it's being written.
Okay.
But what will come out of the end, yes, will be guidance for exactly the reasons you've said. And part of that is about, well, there's a SNOMED interest to that in terms of specifying what SNOMED codes are used. There's also an interest from the HL7 end, which is more tightening up the FHIR specification. Both need to work together to inform the answer to that question. But yes, that will come out of the SNOMED on FHIR work and the collaboration with HL7.
Okay, thank you very much. I had seen that group there, so.
Not a problem. And the same as with other groups, like I said, the information's on Confluence. Go there and follow those discussions.
Okay, then I will read the next question from the question board. So there was the question, how exactly is the mapping between the pre-coordinated and post-coordinated codes done, so that when I could create a query, both queries would be lead to the same patients? Is there, this is one question. Then the second one, is there a lookup for all possible combinations? Yeah, these two questions.
So do the first point. The first point is not around mapping, it's the way that content is modeled within SNOMED. So if you take the pre-coordinated content in SNOMED is modeled using attributes that describe the particular aspects of that concept. There's then SNOMED provides guidance on something called the expression constraint language, which tells you, if you are post-coordinating, how you would link those together. And within SNOMED and within the release, we publish something called machine readable concept model. So within SNOMED, the attributes that are available for a particular concept type in SNOMED has a particular set of allowable values. So for example, if you're describing a procedure, you can use procedure site, which should be fairly evident, I would have thought. What you can't use is finding site. So if you're talking about a procedure, you can't talk about a finding site. You can talk about a procedure site. And equally, if you're looking at a clinical finding, you can't talk about access method because it's not an allowable attribute value for concepts in that area. So the answer to the first point, it's not a map. It's more about the way that SNOMED is constructed that answers that question, along with the guidance around the expression constraint language, which tells you how to formulate a post-coordinated expression. In terms of the lookup, I'm going to pass that one over to Rory because I'm not completely sure of the answer to that one.
The lookup. look up for all the possible combinations. The simple answer, no, there isn't. But as Ian said, the restrictions are defined by the machine readable concept model, which, as Ian explained, you can't attach a leg to asthma, for example, is a really bad example. But yeah, the post coordination is one of the very powerful aspects to SNOMED, so that if there is something that you cannot find, you can describe it by combining different codes and get that post coordinated view. So really, the combinations are kind of limitless to a certain extent, because the combinations don't need to just be 2 codes; they can be multiple codes to create the clinical meaning that you're trying to define. So there's no lookup as such, because it's just a question of combining codes that exist that can be combined together.
So I suppose if the driver for that question is around you doing analysis, it's really about understanding the concept model and how things are modeled in SNOMED. So, it's a very simple example, right? But if you were going to look through your data warehouse with SNOMED codes, and you wanted to identify all the codes that represented appendicectomy, right? So, the procedure to remove your appendix. Those exist. There are a number of appendicectomy codes exist in SNOMED. Some called appendicectomy, then there's laparoscopic, there's emergency appendicectomy, and a number of others. So one way would be to actually go and search through all the terms that you could think of that had anything to do with appendicectomy. The other way, though, which is where Rory's coming from, which is about the powerful the power of SNOMED, is instead of doing that, is to actually go through that data and look for anything which had a procedure site of appendix and a method of excision as part of the defining attributes for any of those concepts. It doesn't matter what they're called. So, well, there isn't one, but if there was a particular type of appendicectomy called an Ian Green laparoscopic procedure that happened to be a particular way to remove an appendix, by searching that way you would find it. By searching by all the individual terms that you could think of, you wouldn't get that back. So it's just a way of making sure that you get high level of data quality in terms of the data retrieval. But it's not really about a lookup, it's more about how you search the concepts. So you search the concepts in terms of going down to the individual attributes rather than searching for the concept descriptions. Is that helpful?
I think yes. Nobody can answer you, Ian. Otherwise, I have to. Is there someone to add something? Then please raise your hand. No. Okay. Okay. It was clear. So good. Yeah, I got the answer. Okay. So far, there was just one other question. Where could I find the OVL ontology of SNOMED CT? But Rory already answered this in the function. So far there are no other questions, but I want to encourage everybody to ask your question, because now you have the experts here, and whatever you want, ask it. They were very happy to answer your question. So yeah, wait a few seconds. Yeah, there was a hand signal. I will from Mr. Spitzenfrei, I will unmute you now, so you can speak.
So, can you hear me?
Yeah,
Yeah.
we can hear you.
Okay.
Yeah.
I have a question regarding LOINC. You mentioned it in regards to China, I think it was. Is it currently implemented in the regular SNOMED or not? Or is there a mapping planned for LOINC?
So we don't produce a map. We produce a map, or we should produce a type of mapping file to some LOINC expressions. We attempt to put the LOINC parts into SNOMED. If you're familiar with the way LOINC is implemented, in practice, you tend to use something called Realma, which is their expression builder, which basically allows you to create a term from specific parts or specific concepts, if you like, within LOINC. Whilst we can work on supporting containing the LOINC parts within SNOMED, we will never be able to do the LOINC expressions, because if you think of all the different axes that you can possibly go through as part of that, the only way to do that, if we went down the pre-coordination route, would be to create literally millions of codes because of all the different variances. By producing the parts, it then allows you potentially to post-coordinate the required concepts. So the answer in a roundabout way is yes, we do, and no, we don't. So no, we don't produce individual codes for everything in LOINC, but we do provide the components for you to build any of the things which are in LOINC. In terms of the mapping, at the moment, we've had an agreement with LOINC in the past. That agreement currently is being reviewed. And I don't want to kind of try and pre-guess what's going in the agreement between two organisations, particularly as I'm not the one involved in the discussions. But we certainly do have a partial expression map between LOINC and SNOMED, which more gives you advice on how to do that, as opposed to giving you a complete mapping, which we would never do. Does that make sense?
Yeah, I was actually very surprised, consider that LOINC is really, really complex, and I'm actually very happy with the answer.
Excellent. Well, I'm glad we're doing what you want.
Okay, thank you very much. There is a new hand signal of Mrs. Toon. I will unmute you now, Mrs. Toon. No, you can ask a question.
Hi, Iron. This is Sylvia. So I'm curious about your status of your cooperation with the WHO and the ICD development.
So hi, Sylvia. Nice to talk to you again. Okay, so at the moment we have an internal project looking at ICD-11 and looking at producing a map between SNOMED and ICD-11, the MMS, right? So we're looking at mapping to the MMS, not the foundation layer. One of the challenges we have about doing the work with ICD-11 is finding a stable version of ICD-11, which is a bit of a challenge, as I'm sure you're aware. As far as working with the WHO is concerned, at the moment, we are still talking with the WHO. There are ongoing discussions about what that will look like in terms of SNOMED and ICD-11 going forwards. So I can't answer that question other than to say it's a work in progress. There are, which I know you're aware of, there are some issues between how ICD-11 and how SNOMED will interact in the future, not in terms of the organisations, but in terms of the individual products. So yes, at the moment it's an ongoing discussion. That's all I can say at the moment. But thanks for the question, Sylvia.
Thanks. I think it will be better in the future because Germany joins the IGDSTO, and as you know, that DIMD, or now it's BfArM, and my colleagues there are very keen to work with SNOMED and to understand much more about SNOMED. So, and they are responsible for the ICD-11 development as well. So perhaps this is a big chance for us, hopefully.
Well, I think it's so. Yeah, Germany's the one country who is looking at joint implementation, and their aim is to be one of the first countries to do that. Is Israel, and I actually had, so before all the COVID outbreak, we had representatives from Israel come to the UK just before Christmas, and had about a 3-day session with them, running through a lot of their implementation plans for SNOMED and ICD-11 and how they're looking at implementing that in Israel. And yeah, we don't need to do that on this call, but when DIMD come to actually move that forwards in Germany, I would suggest, it's entirely up to you, but I'd suggest you contact me, and I'll get in contact with Israel and get the two of you discussing one, how to do that based on some of the experience Israel will already have of doing that, which will be a useful conversation going forwards, I think.
Okay, thank you, Mrs. Toon. There have been 2 new questions in the meantime. So one is, are there useful applications or examples for reasoning across SNOMED CT?
So the answer to that is yes. I'd point you, for that one, I'd point you to SNOMED in Action. There are a good number of implementations that do that, and a lot of those are actually written up as use cases within SNOMED in Action. So go and have a look at SNOMED in Action, seeing what's in there. It'll also tell you the individual organisations doing that if you want further information. If you either don't know the organisation involved or can't contact them, you can email me, and I will put you in contact with the various people required.
Just to answer the second part of the question, because I think it was more about reasoning across SNOMED. So SNOMED CT is authored using reasoners already. So if you run a reasoner across the SNOMED CT ontology as it is that you would download, you will get no extra results because it already has an inferred view which has been created by a reasoner. So there is no need to run a reasoner across the SNOMED CT releases that you download.
Okay, thank you. Then the next question is, what mappings are available into SNOMED CT?
So that one is an interesting question. The one that we get asked for the most is the one which we don't do and would actually be the hardest to do. So as I said earlier, we produce a mapping from SNOMED to ICD-10. What we don't do is a map from ICD-10 to SNOMED. So for people who are familiar with mapping, the SNOMED, the ICD-10 to SNOMED would require a one-to-many map. So what that means is you'd have a single code in ICD-10 and then a list of multiple codes in SNOMED. In terms of doing analysis, that is almost useless in terms of you have no idea which of those terms in SNOMED would be the correct one to use in the circumstances, unless you look at all the other context in the electronic record. In terms of some of the other mappings, although we produce them in terms of SNOMED to something, effectively a lot of them will be, by their very nature, will be multi-directional anyway. So if you look at the map that we're producing between SNOMED and Orphanet, it's basically a one-to-one map. So it's a SNOMED code mapping to an Orphanet code, and therefore, you know, the vice versa, the opposite way around, also holds true. That's particularly true with Orphanet. It will be true with, well, it is true with the nursing reference sets and reference mappings, and also with the dental mappings for exactly the same reason, because they're one-to-one mappings. The difficulty is if you've got any of the maps which are rule-based, they will always produce a one-to-many map, in which case, one, you could produce one, or it's possible to create one. We don't, but it is possible to create one. But if you did, what you're creating is almost useless, because you can't automate the use of that map in any particular way in terms of data analysis, in terms of data aggregation, without the rest of the context of the individual patient records. Is that helpful?
Yes, it was. Okay. Yeah. Okay. So, are there any other questions? Now you have the possibility. You raise your hand or write it to us. Okay, there was just a comment, but sometimes it would be helpful or useful to have hints. Yeah. So, to what you said, Ian.
Sorry, I missed the bit. My connection just broke up. Sorry, can you repeat?
Yeah, but sometimes it would be useful to have hints concerning a semi-automatic mapping. Yeah, so that's just a comment from the
yes,
question.
yes, I agree.
Yeah. Okay. Yeah. Okay. Are there any further questions? So we have. Okay, there was just another comment. Any comments about UMLS mapping to SNOMED? Could you please also make a question out of it?
So sorry, which mapping?
UMLS mapping. Also UMLS. I'm not sure what UMLS is.
Oh, UMLS mapping.
Yeah.
Right. So UMLS actually does already have it has SNOMED in it, and UMLS actually does have a map to SNOMED in it. The map is based on, as with all maps in UMLS, actually, is based on text matching. So the map which exists in UMLS is not always as accurate as it could be. But we won't, well, we at an international level would never produce a map to UMLS, but UMLS itself produces a map to SNOMED anyway.
Thank you. Any further question? Okay. If not, so we have to some time, but if not, now is your last chance. Okay, I would just want to, okay, there was another question. Have there been cases of illegal use of SNOMED? So without licensing, I guess.
So yes, it does happen.
What are the consequences?
So the consequence for us, where we become aware of it, we follow up with them and try to come to some degree of amicable agreements between the two parties and to move them forward to license use. If you're asking that in terms of do we take them to court, so do we go down the legal route, the answer is we try to avoid that, but we would never not have that as part of the options going forwards, but we wouldn't choose to do that normally. We'd much prefer to have a conversation and negotiation with the people using it.
Yeah, okay, thank you, Ian. So you still have some time if you want to ask a question. I want just to take a note to you. So the files of today's webinar will be available. Yes, just one moment. And so if you know, I'm not sure if everyone knows it, but the National Research Center has its own website. The URL you can see right here beyond the screenshot, and there will be a link so that you can download the files and also further information, so that everyone can use the information of today. You can also share it with your colleagues. Okay, so in the meantime, there were no further questions and also no hand signals. Then I think I would thank everyone for their questions and being part of this webinar. And of course, I want to thank Ian and Rory for their time and for the great introduction into SNOMED CT and for the possibility to take this webinar. Thank you very much. And with this,
Okay, thank you.
Okay, Rory. And
so
then
I'd just like to say to everybody on the call, one, thanks for listening. Thanks for listening to me for a long period of time. But also encourage you, as I said earlier in the slides, one is to go onto our conference site where you'll find a lot of information. If you do have individual queries that you think of in the meantime that you haven't had the opportunity, you didn't think to ask here, please send through any queries to info@snomed.org, so our help desk, and we're happy to answer any queries going forward. But thanks for listening.
There was just maybe, Robbie, could you please have a look at the last question? There was an a small user question. This file was missing from the installation folder. I got an error while loading the MySQL script. So maybe if you could answer this one.
I think the quick answer will be, if you'd like to send us an email with exactly what you're trying to do, and send that email to, I'll write it in response to the question. It's techsupport@snomed.org. If you can send that to us, then we'll have a look and see what happens. The file should be there. I mean, there's no reason why it's missing, so we can just see if something else is happening. But send us an email for any questions, and we're happy to help.
Yeah. Okay, she will do it.
Great.
Yeah. Okay. Yeah, we see the email address. Okay. Thanks very much. Okay, then, yeah. Again, thank you. And with this, I want to end this webinar. I wish everybody a productive day and a nice weekend. And yeah, see you soon again.
Great.
Yeah.
Thanks very much.
Thank you.
Thanks. Bye.
Bye. Bye-bye.
Bye-bye.